Our next speaker, Dr. Charles Mastrovich, received his dental degree from Northwestern University in 1976. He completed a GPR program practicing north of San Diego, and in recent years he's had a lot of experience in restorative dentistry implant systems and mechanics with a specialized expertise involving safe retrieval of failed implant components. In fact, he's completed 400 what he calls IMR, implant mechanical rescues, retrieved fractured crowns, fractured screws, and abutments. Dr. Mastrovich. Thank you.
Thank you. Well, thank you, Dr. Goodacre, and thank you to the Academy for the invitation to come and join this group this afternoon. It's really a pleasure to be here. If you look at occlusion and the mechanical steady state, and that's what we're really talking about, a mechanical steady state and how things might break. The question is, this is not it. These are all components that came into my practice, fractured and have been retrieved, and through what Dr. Goodacre said is IMR, implant mechanical rescue. You know, if they break in your practice, it's an emergency, and if they're coming into mine, we have control of the situation. We understand what's going on, so it's a little different, a set of parameters for us. So the first question we had was, how do you recover components safely and efficiently? And we spent a lot of time working with the instrumentation and doing that. So when you do one effectively and efficiently, it's successful. And we can call that IMR. But this area actually is out of the scope of the presentation, but I want to make one point. And the point is, if you're not used to doing this, be very careful with going into that implant with especially rotary instruments, because it can get out of hand real fast. And all of a sudden, IMR becomes something else, and it's called I married the results. So you don't want to go down that road. Probably the reason I'm here, though, is to talk about the whys. Why did it break? What was the etiology of failure? And it always intrigues me when things are coming in to take a look at that. And because the idea is failure is expensive, and it's expensive for all of us when we do it, but it's also a majorly powerful learning tool. And if we can learn from failure, we can also hopefully enfold that back into our treatment planning processes. And if we can decrease failure, of course, we can increase success. So when I first started preparing for this, I thought of three basic questions. And the first question, of course, was, does component system failure relate to occlusal design? And, or is it really based upon a patient-based failure? In other words, not all patients are the same, and some seem to break everything, like Dr. Chi just showed. And, or is it an inherent difference between implants and teeth with the loss of the ligaments and et cetera? And we'll show a little bit of that in a moment. Or is it just a random, unfortunate event that occurs in some of our patients, and we just have to sort of live with it? Well, we know it's an unfortunate event, of course, but is it random? Well, I don't really think so. Two, are there other issues driving failure in this situation other than occlusal design? And the next three are design and tolerance fit of the implants and the components. Dr. G just showed some components that had limited screw function. And so that's the implant manufacturer's end and what we choose. The number and size and position of implants and components of where we put these implants and how we distribute the loads is on us. And accuracy and delivery of the case and taking cases to completion, that's also on our plate. And there's a third question I asked in this, what's the common denominator, or is there a common denominator that we can hook all these things together? And I believe there is. If we go to this just simple mechanical equation, a vertical equation. So we have a mechanical system on one side, and it's being acted upon by forces on this mechanical system. And we know that if there's no directed force on the mechanical system, there's no damage to the system. It can just sit there. So where does the force come from? Well, obviously it's muscle function coming, and it's kind of a dynamic engine that supplies the force. And so in this, a dynamic load on a mechanical system is a load that's going onto the system versus like a static load, and a static load like intrinsic into the system itself. And an example would be maybe a misfit framework that the screws go down on the framework, and it's a 24/7 internal load. But we're really talking about dynamic load, repetitive loading on the mechanical system. So what delivers this dynamic load onto our mechanics is implant occlusion that delivers this force. And there's a lot of different aspects to this occlusion that does that. So let's take a look at Herman here. And Herman can tell us what we know about all this stuff, and we know a lot about the anatomy and where this force comes from. We know the muscles of mastication provide the dynamic force, and we also know that it's a class 3 lever system with the effort and the load being on the same side of the fulcrum, which is the TM joint. We also know that occlusion is the delivery system in one form or another. And experimentally, there's a lot of studies that show that, the experimental range of somewhere between 200 and 1,500 newtons, which is a pretty wide range of force on the posterior teeth, that's what we're working with. The problem is that what we don't know in this situation is, in any specific case that we're working on, what are those parameters? What resultant forces are transmitted to the teeth, implants, and the restorations in any specific case? Okay. So let's look at mechanical system damage, and there's a couple statements that I kind of like to keep in mind. The first is a real simple one. This: when forces exceed the ability to resist loading in the mechanical system, system damage can occur. That's pretty obvious. Put a big load on it, or a repetitive load over time, and boom, you get problems in the mechanics. And joint mechanic fails is a little sneakier because, again, it's an external load on the joint that tends to separate or decrease the tensile forces on the screws. So I really think of that screw failure and screw loosening is a function of the geometry of the joint not being able to protect the screw from external loads. Okay? So going back to the three questions I have here, we know that force is the common denominator that loads up things. We know that in the patient base, there's a wide variability of how much force is being put on any particular case. Occlusal design here, I changed one word craftily and I put occlusal function, because occlusal function of how this delivers the force on our restorations matters. And then the three things down below are all about the mechanics of a system that we put on. So there's the equation. So if it was a multiple choice question, I have to put number 4 in here, and it's all of the above. I mean, in reality, and if we forget any of these, it can be a problem. So let's go to a quick little force diagram here. Let's put a 600 Newton load on an implant in an axial load, straight down the middle, and everything is happy mechanically. The component stack is loaded vertically, and the bone is in compression, so everything's happy. If we put a 10 millimeter crown on here, and we move the load over to a periphery like a marginal ridge or the whole occlusal table, and we put a 3 millimeter cantilever on this system, and so we end up translating that into an 1800 Newton millimeter moment or torsional load. Okay, so now the screws and the abutments and the components have to resist that. Is that a problem? Well, I don't know. Here's a routine predictable case I'm going to show you that came into the office, and this was Bud in 2009, had 2 implants nicely placed, good bone, etc. And then we look at him 4.5 years later when he shows up in my office, number 31. That's number 32 to the left is still present, and so he has some proprioception back there. But Bud in 4.5 years did enough cyclic loading on this case to fracture this abutment and fracture the screw. So what happened? Well, it's not a routine case anymore. And is it predictable? Well, not quite as much as it was, but it is predictable in the expense side. It costs more money because someone's going to have to pay for Bud, because Bud's probably listening to the radio and he's heard that, you know, just a few implants in one arch can solve his problems and he doesn't have to go back, you know, anymore to the dentist. So what happened here? Well, the axial loads on this, right down the middle, right through the screw axis, everything was placed well. But look at where the torsional loads are. You know, the distal marginal ridge, the buccal cusps, and the mesial margin. The whole occlusal table was the bolus, crushing these boluses in the size of this table was enough over time to create enough torsional loading in this to work harden and fracture that titanium. Okay. Now, if we go back to an anatomical section, here's a natural tooth, upper molar, and you know this molar had millions of years of evolution head start on us, you know, and it's pretty cool because how it's been designed, and it's even a self-assembly system when you think about it. But we put an implant in here, and it's a smaller diameter, and we put an abutment on it, and if we actually load it, you know, everything works kind of the same, you know. But we can't actually load a molar restoration because the restoration is larger than the implants that we have. So then we have a load coming down, say, the lingual cusp. Look at how the tooth handles that load with that lingual cusp, lingual root sitting there, and the implant starts to get torsionally loaded. And it gets worse if the occlusal table, like in Bud's situation, was wide or broad or flat, and it takes more load to crush the bolus. And so torsional loading adds up. Now, another case that came in the office in 2015, Maureen, this was kind of interesting. It was referred in because she had a broken screw and a single tooth restoration again. And so I looked at the case, and it wasn't the broken screws down there. You can see it in the blue arrow, but really the problem is a broken implant on this lingual sidewall. There was a 44-degree, I put the analog up there too, so you could see the 44-degree lead-in bevel was fractured off on the lingual side. So we recovered the screw for them so it would be easier to explant the implant. And then on her way out, I took a quick picture of the scope because I saw these vertical fractures in her bicuspid. So I asked Maureen, I said, how did you lose your molars? And she said, well, I fractured them. I said, no kidding. And so look at where this implant was located relative to her arch, and it was to the buccal by a good 3 millimeters. And if you draw a line on the lingual cusps and then you put the torsional loads, that the force vectors on there, you can see right where the fracture occurred on the lingual. So I don't think this is my research here. But when you look at it and you put the implant back into the middle of the ridge and you put the force vectors on that one, you can see the difference will be probably half as much. Okay, so look at Maureen from the front and look at the frontal view and look at how much bone she's actually built in these tori. She's massively built bone, and so she's really a candidate. You know, all the signs are there of massive function on these teeth. Okay? So if we go back to our little diagram here, and we're going to just kind of quick-like analyze that and say, okay, what happened? Well, the implant was to the buccal by another 3 millimeters, so we're going to put 3 more millimeters on that torsional load. But instead of a normal, like a 600 millimeter chew cycle there, I'm going to give her the upper end, though, like 1,500 newtons, just for argument purposes. And now all of a sudden we have like 9,000 Newton millimeters of torsional load sitting, and guess what's going to get it? You know, it's that sidewall in that particular joint took a beating. So if you take and compare that to like a little bit more normal bite on like say a 15 millimeter cantilever, posterior cantilever, move that out there, that's 600 newtons, it's force times leverage arm, gives you a 9,000 Newton millimeters a moment torque or torsional load. And if you put them up together, You see, the numbers just happen to coincide. And so but you look at this and you say, okay, at the top we have patients are totally different. She can chew like a gorilla, and she has a gorilla bite, and you have more torsional loading, and there's a reason that implant broke. So look at this one. This is like a 15 millimeter posterior cantilever case that fractured, and it did about 4.5 years on this titanium framework, and the lady was about 88 at the time. So you can see that it wasn't a surprise when Maureen lost it there. Now, when this case came into the office, it was for retrieval of that upper number 15. But what was so interesting to me is the lower right. And I don't become speechless very often, but when I saw this X-ray, this lower right, I said, "Good golly, look at the torsional loading on these two molars, implant position. There's just nothing that is biomechanically correct to give this young man really longevity in this case mechanically." And this is an interesting case that hasn't come in yet, but it's just referred in, and I put it in last week because look at the torsional loading that occurred on this and the abutment breakage. The problem is that you think, well, how long did it take to break? This implant, these two implants were in the mouth for about 13 years. But the really interesting fact about this is there was no posterior occlusion in her mouth when she was examined by the prosthodontist that sent her in. So all she does is function on her anterior teeth. Now, it may not have been that way for the last 12 years, but it was certainly that way now, and she broke it. Maybe that's why it lasted as long as it did. So what do we know and what don't we know? Well, we do know that muscle function is a dynamic engine driving all this loading and all this function, whether it's function or parafunction, and it tends to work through what we've built. Occlusal parameters deliver the load in one form or another, and case design and how we place our implants and our locations and and we get even loading is very important to how much load that we actually put on it. Unfortunately, what we don't know in these situations is there's no way of pre-calculating the resultant forces in any particular case. And what each implant pillar is designed to withstand, we don't have all that data either. And even if we did, how would you match it up into the particular case? And what forces are ultimately destructive in repetitive loading? That's another whole aspect. So how do you deal with all this? Well, we know it's a multifactorial equation to keep cases together. And if we forget one aspect or another, those facets can come back and kind of be the perfect storm like Maureen was. So I think you have to think in terms of essentially over-engineering a case from the start. I think force from day one when we're looking at radiographs, I'm looking with the surgeons, I'm thinking implant size, they're thinking size of the bone bed to keep the bone bed stable. So you can't go out of balance on either aspect. And so really what I'm thinking in my mind is belts and suspenders approach for mechanics. I want to, and a lot of engineers think the same way. Use systems and components with robust engineering. And the question is, what is robust engineering? We're dentists. We know, we had physics 101, a long, long time ago. We think in terms of stress, stability on bridges and this and that. But I think we need to think like engineers because implant dentistry is a lot of mechanical engineering. We have parts, pieces. We need to know how screws work. We need to understand there's no perfect fits. There's tolerance in the machine shop. And all that stuff matters. Two other factors that I'd kind of like to touch on for a moment, and that's one thing that I try to shy away from, and is avoid ganged abutment connections. Do you notice that the two cases I showed were both single units? And I see a lot of single unit breakage in the back, in the posterior. And so if you take a ganged abutment, like say in a small diameter, and port it up to a larger diameter implant, you have a thicker wall, but you also have a thinner abutment wall. So I see a lot of abutment fractures in that scenario. Not so much of a problem if it's a larger size implant ported up to a slightly different diameter in the large end, because the components are already a lot stronger. But I really think in terms of that scenario. And the other thing I think is kind of being out there a little bit more is be cautious of third-party components. I'm not saying don't use them, because there are potential situations that they might actually even be better. However, there's only two reasons I would understand to use them. One is if the OEM company doesn't supply the parts that you need, number one. And number two, it's dollars. So you think you're saving money with buying these other components, and in reality, the money you save going into a case may be a fraction of what you end up spending if parts fail and the warranties are void in the situation. So I would be careful of that. There's some factors that you may not be able to judge, and I would say that there's issues called patent infringement limitations. If a third party can't engage all the features of an implant that's still on patent, if an implant connection is off patent and they're duplicated out there, the problems that were potentially with that connection early on will probably be with the duplicated one as well. And then there's also the matter of tolerance fit, which I don't think, generally speaking, today should be a huge issue because of the CNC manufacturing and whatever. But I just be cautious, especially when you have small diameters, and for crying out loud, don't put cement and other issues into the screws and the abutments. I've run into that as well, and nightmare situations. But anyway, limit torsional loading as much as possible. I think I've showed that in the cases that I've had. I think if there was one take-home message in there today, that would probably be it. Limit mesial and distal and buccolingual sizes, especially on small pillars, and also decrease posterior cantilevers whenever possible, because they accumulate so much stress. And then I think there's no substitute for excellent treatment planning, building the cases with precision, and adjusting the occlusion with care and precision to try to avoid even the small fractures and things. And with that, thank you for your attention.